Alrighty. Thank you so much, and good morning, good afternoon. Welcome to the December meeting of the International Noma Network. We are extremely grateful and excited today to welcome Dr. Yuka Makino from the WHO Africa region to celebrate with us the 2-year anniversary of Noma's inclusion on the WHO's list of neglected tropical diseases. Dr. Yuka Makino has been a technical officer for oral health at the WHO Africa Regional Office since August of 2019. Her main responsibilities are to implement the global and regional strategy on oral health and Regional Noma Control Programme through supporting member states to develop and implement the National Oral Health Policy Action Plan and building the capacity of the focal points of oral health at the Ministry of Health to accelerate oral health agenda. Dr. Makino holds a PhD in Preventive Dentistry, a Master of Science in Public Health, and a Doctor of Dental Surgery. Thank you so much, Dr. Makino, for joining us today. We are extremely grateful and excited for this exciting webinar. So thank you so much for being with us.
So thank you very much, Dr. John, for your great introduction. And then I'm very happy to be with you today, especially today is actually 15 December. In 2023, the 15 December, that day, Noma was actually recognized as a part of the WHO NTD list. So I start to share my screen. In case if you cannot see my screen, please let me know. I hope you can see my screen.
That's perfect. Thank you.
So thank you very much. So again, this is Yuka Makino. I'm a focal point of oral health, including NOMA. So today I'd like to talk about from recognition to action, positioning NOMA within the NTD. So maybe some of you already saw this video. So this video, animation, mixed video, both the video from the field and also animation. This is actually, we try to develop this one for the raising awareness of NOMA, especially for the policymaker and also public health practitioner. So you can download this video through scanning this QR code. And then this video, I will show you in English now, but you can also access French and also Portuguese as well. So it takes around 4 minutes.
Imagine a disease that destroys your ability to eat, speak, see, and even breathe, causing severe damage to your mouth and face. This is NOMA. Most cases occur in Africa, but it is also found in Asia, the Americas, and beyond. Without treatment, many NOMA patients may not survive. Those who do often suffer debilitating facial disfigurement and exclusion from their families and communities. But it doesn't have to be this way. NOMA is preventable and treatable. WHO defines NOMA as a severe gangrenous disease of the mouth and face. The disease is not contagious and mainly affects children aged 2 to 6 years and progresses through 5 main stages. In stage 1, gum disease leads to a painful infection of the gums, also known as necrotizing gingivitis. This stage also includes gum bleeding and bad breath. Next, facial swelling or edema and fever develop. During stage 3, gangrene then sets in, cutting off blood flow and destroying facial tissue. Without treatment, many people die in this stage. In stage 4, survivors face severe scarring. In the final stage, long-term effects include difficulty breathing, speaking, and eating. Some may even develop eye issues. Survivors often require reconstructive surgery and physiotherapy. NOMA is diagnosed clinically. There are no diagnosis tests available. NOMA can be prevented by addressing potential risk factors. These include improving oral hygiene, reducing malnutrition, ensuring access to water, sanitation and hygiene, and increasing vaccinations against associated diseases like measles and malaria. It is also important for communities to know that Noma is not caused by witchcraft. Working together to combat Noma. Since 2001, WHO in the African region has led efforts to reduce Noma cases, supporting health ministries with guidance, tools, and training. With the support of partners, including German NGO Hilfsaction Noma, WHO has helped priority countries, mainly in West Africa, to develop and implement Noma control programs. In 2023, WHO classified Noma as a neglected tropical disease, NTD. This may lead to increased awareness, investment, funding, and a more integrated approach. No more Noma. No child should suffer from this preventable, treatable disease. WHO is working with partners to support countries in adopting a more integrated, people-centered approach to Noma, alongside other NTDs and key issues like oral health, nutrition, and vaccination. This includes training of community health and primary care workers on early detection, diagnosis, treatment, and referral. Community awareness campaigns to promote health, early detection, and dispel myths of Noma. Integrating Noma into national health information systems and conducting Noma screening during the mass drug administration of other NTDs and vaccination and nutrition campaigns, leveraging existing wound care and referral systems. Let's unite to improve inter- and multi-sectoral collaboration to fight the root causes of Noma. Join us.
So thank you very much for watching this video. Hopefully this will be also useful for you to advocate Noma among your community as well. So because today's, I know that most of you already familiar, and then most of you is a researcher for Noma. Therefore, this background information is maybe already you know everything. But Noma is a rapidly progressive, invasive, and debilitating orofacial disease, and then that affect most vulnerable and marginalized population. But maybe I can also highlight it that final sentence because as mentioned in the beginning, because people still coming to the presentation. Therefore, I just would like to highlight it that 2023's 15 December today, actually WHO recognized Noma as a part of the neglected tropical disease list. Therefore, today is actually the second birthday of the Noma being part of the NTD. Therefore, I'm very happy to be with you to talk about Noma this very historical day. So I just would like to highlight the geographical distribution of Noma because this map would be relatively new. As many of you know that we don't have a global comparable data on Noma. Therefore, in order to develop this Noma map, distribution map, we actually try to utilize existing two systematic review. One is actually published in 2022, Lancet Infectious Disease, led by Dr. Anais Geri. The other one is recently 2025, the Oxford team and also WHO published one of the scoping literature review in the BMJ Global Health. And also, we also tried to combine some of the data reported to WHO to develop this distribution map. So we tried to gather information between 1950 to 2023. And then we could identify the country reported Noma data, 90 countries during this period. And then we can divide these 90 countries into the three categories. Of course, we also have a data not available country. Therefore, if we include that no data available country, we have a 4 category. But one category actually historical reported case between 1950 to 2009. And then recently reported case is actually only after 2010 to 2023. And then continuously reported case actually between 1950 to 2023. So you can see the categorization based on the color of this map as well. So among 90 countries, 58 countries categorized as a historically reported country. And then 13 country, actually darkest green country is continuously reported country. It means that 1950 to 2023, they reported the Noma cases. And then 2 countries, I think that is Bulgaria and Croatia, that data coming only between 2010 to 2023. So what you can see is, people also feel that the Noma data is mostly coming from Africa. But in case that this factor, potential risk factor exists, beyond Africa, we also can find a case from the other region as well. Then, as mentioned that after integration of Noma into the NTD list, there is some progress related to the Noma after integration of Noma into NTD list. So today I will discuss about the 4 information. So one is related to normative work, especially facilitating inclusion of Noma into the NTD roadmap. The second one, I also would like to discuss about surveillance and data. Then third point, maybe, all of you more interested in maybe research issue, and also tool for raise awareness. And also fifth is actually country level activity. So first point is related to normative work, facilitating inclusion of Noma into the WHO NTD roadmap. So some of you already know that we have a WHO NTD roadmap. Actually, that provides a guidance to achieve NTD target by 2030. But this roadmap was actually developed in 2021. It means that at that time, Noma was not part of the NTD. Therefore, currently, we try to integrate Noma into this NTD roadmap. Therefore, currently, we consult with the expert to develop the disease summary for Noma. So that includes endpoint of targets. So, we would like to propose what kind of target we should achieve by 2030 related to Noma. And then we also provide some of the indicator and also core strategic intervention such as water and hygiene sanitation, case management, and etc., etc. And then we also provide the burden of disease. But at the same time, we also try to create the gap assessment tool exercise. So because as you know that currently, including Noma, we have a 21 NTD. And as you know that Noma is actually newest NTD. Anyway, so 21 NTD, we have actually 11 dimension. So this gap assessment is quality assessment across all 21 NTD to monitor progress the target for, toward the NTD 2030. So as mentioned that we try to identify what is the situation related to 11 dimension for 21 disease, and we try to give the color. Red is actually delay, and then the orange is also a bit, slow progress, and then green is actually, on track. But anyway, so this 11 dimension includes such as monitoring, evaluation, diagnosis, access, and logistic and funding. So in addition to develop this disease summary for Noma, we also currently consultation with the expert group. We try to color coding and also what we need to do in terms of the Noma implementation toward these 11 indicators. Hopefully we can also publish this information soon as well in alignment with other 20 NTD. Then another normative work is, as you know that before, integration of Noma into NTD, actually global oral health program and also regional oral health program actually leading Noma prevention and control activity. We still also continue, both NTD team and the oral health team to tackle Noma in WHO. But actually in 2022 and 2023, WHO Global Oral Health Program actually produced, based on the country's request, we produced the WHO Global Oral Health Strategy and Action Plan in order to achieve universal health coverage for oral health for all by 2030. And then we are now working in the WHO regional office in order to translate this global strategy and action plan into our regional context. This year, during the regional committee for Africa, So every year we have a regional committee for Africa, and then we have a 47 member states under our regional office, and then the delegates from the 47 member states come together to discuss about various health agenda. I mean, each regional committee. Then this year we had a 2 agenda for oral health. One of the agenda is actually regional framework to accelerate implementation of this global oral health action plan in African region. So if you're interested in this strategy and action plan, you can also download these materials through scanning this QR code. Then this regional framework actually tries to achieve universal health coverage for oral health for all in our region by 2030. And then our target and goal is quite similar with global, strategy and also action plan. However, we also modify, considering the regional context. And then as you see that, we have a 1, 2, 3, 4, 5, 6, 7, 9. So 9 indicator, target and milestone. And especially if you see the milestone 2028, we have a milestone related to NOMA. So NOMA integrated into national policy. That means, whether it is integrated as a part of a national NTD master plan or oral health strategy or national strategic plan. If the country, NOMA endemic country, whether integrate NOMA as a part of this, we actually set one of the milestone. Therefore, we ensure that NOMA can be controlled our region by 2030. Therefore, of course, we have a global NTD roadmap, but at the same time, we also have a global oral health strategy and action plan, but we also have a regional strategy in Africa in order to accelerate the prevention and control of NOMA. Then in terms of the surveillance and data, so already NTD, they have a global NTD program annual reporting form, so called GNAF. So annually, our WHO colleague in collaboration with both regional office and country office, we try to collect, in collaboration with Ministry of Health NTD focal point, we try to collect all 21 NTD data. Then from 2024, we start to integrate NOMA as a part of this GNAF in order to get the integrated integrated NOMA information through this facility-based indicator. Then, because this result is actually first year result after integration of NOMA into the GNAF, therefore, as you notice that, the country reporting on the endemicity status of NOMA, only 7 countries actually reported that their country potentially can be the endemic NOMA country. Then the 5 countries also reported that whether their country includes NOMA into the national NTD master plan or action plan or not. And then out of 5 countries, only Burkina Faso and Mauritania say that they are included as a part of their national plan. Then in terms of NOMA case, because as you know that, of course, we don't have much data on NOMA, but definitely in our region and beyond, more than 4 countries actually reported NOMA, but through this first year of the GNAF, we only received the 4 country information, Burkina Faso, DR Congo, and Mali and Senegal. And then actually these 4 countries reported around 440 cases, but that is actually suspected case. Only DR Congo and Senegal actually reported the confirmed case. Therefore, as you notice that, we started to do the integrated data collection, of NOMA in line with other NTD, but still we are very new. Therefore, many countries have not yet submitted that data. Therefore, we also try to encourage Ministry of Health NTD focal point and also oral health focal point to report NOMA through this GNAC platform to understand better situation of NOMA, not only the epidemiological information, but also health system information as well. Then research. So as you noticed that, I don't know whether today our colleague from Swiss Tropical Medicine team joined today's meeting or not, but in 2024 September, actually Swiss Tropical Medicine team organized a hybrid symposium. Actually, more than 100 participants joining, including people living with Noma. And then based on this consultative process, they could identify 8 priority areas, which need to accelerate for the Noma research agenda, such as clear case definition of Noma, and also early detection and robust surveillance, and also psychosocial economic impact of Noma, and then decision support for diagnosis, and also associated antibiotics treatment for Noma. Then in WHO, we work together with NTD team, research team colleague, especially inclusion of Noma in the WHO NTD research and development blueprint. So this blueprint try to identify R&D priorities that could lead the significant advance, and then broad-based consensus building process. I think, we also did some of the public consultation already. And then this prioritization include basic clinical, social science, and epidemiological research, including health product development and operational and implementation research. Therefore, this, R&D blueprint is actually scope is very broad research area. Then the NOMA is, as mentioned, that the part of that last and then the newest NTD. Therefore, this is, NOMA is also part of this NTD R&D blueprint exercise, and we are now currently ongoing process of the research prioritization activity. Then another thing is when I introduced the map in the beginning of my presentation, one of the paper which we utilize to extract the data in order to develop that map is this systematic scoping literature review on NOMA, evidence landscape, current knowledge and gap. This is just published in this year. You can also download this scoping literature review scanning this QR code. So purpose of this scoping literature review is to systematically review all primary research on NOMA to map existing evidence and identify gap in understanding, prevention, and treatment. So I also would like to summarize the main findings of this scoping literature review. So actually the around 366 publications from 69 countries satisfy the inclusion criteria of this scoping literature review. And then type of the study is 53 cohort and then 29 cross-sectional, and then only 6 is actually interventional study. And then in terms of treatment, we identify 380 modality, but we could not identify standardized practice. And then etiology, we could identify more than 110 microorganisms reported, but non-consistency across all the papers which talk about the etiology. And then geographical distribution, of course, because more research happened in Africa. Therefore, since 2000, in Africa, especially Sub-Saharan Africa, the more than 90% of cases coming. But as you already know that, reporting coming also other regions such as Asia and America. And then risk factor, we also identify more than 200. However, the risk factor is highly heterogeneously. And then in terms of staging, because we also check, these paper, which kind of staging of NOMA utilize, actually definition, case definition is different, depend on the research. Therefore, we also would like to emphasize that, each research also need to utilize the WHO classification. As you know that we have a 5 stage. So stage 1 is necrotizing gingivitis, stage 2 is on-demand stage 3 is actually ganglion, and then stage 4 is actually scarring stage, and then 5th is actually sickle stage. Therefore, this paper also emphasizes that it is important to utilize a universal classification of NOMA in order to understand the better situation of NOMA. Because today we have many researchers joining this meeting, therefore, I also would like to highlight some of the key findings and recommendations coming from this paper. So actually, I have 10 key findings and also recommendation. So some of them is, already I mentioned many times, before I come to this slide. But anyway, so first one is a reported NOMA case since 2000 indicate that its prevalence extends beyond the traditional NOMA belt, with case also occurring in other African countries and also Asia and America. So recommendation is global efforts should prioritize robust surveillance and epidemiological study and expand NOMA education, including training for primary care and community worker beyond high-risk country. Then the second one also quite similar with the finding from the first bullet point. There are significant variance among the few reported burden of disease indicator, with most estimated based on retrospective study, small sample size, and local survey. So to better understand NOMA global distribution and burden, population-based studies should extend beyond the NOMA belt, and also systematic national reporting should integrate NOMA into both active and then passive case surveillance. Because, as you notice that, because NOMA patient could not be reached the health facility. Therefore, not only passive case surveillance, but it is also quite important, especially integrated active case surveillance. For example, during the master drug administration of the other NTD or nutrition or vaccination campaign, it is also important to integrate active NOMA case surveillance in order to understand the NOMA situation better. Then another point is, yes, this is actually linked with my previous slide explanation. The definition and the stage of NOMA progression are poorly standardized and then reported across the literature. Therefore, I also would like to emphasize one more time that it is important greater awareness of WHO5 key stage of NOMA, and then use these criteria in both the case definition and reporting is highly recommended. So another issue is, as mentioned, that the risk factor, because we actually identify more than 200 potential risk factor identified across 269 publications, but risk factor for NOMA show wide variability, and the limited patient level reporting with weak evidence hinder assessment of their causality and interdependence in disease progression. Therefore, collect and report risk factor and comorbidity at the patient level is very important. And then design study to examine their association with NOMA using appropriate statistical method to control confoundings. And then establish reporting guideline to standardize the inclusion of details like risk factor and also country origin, and improve reporting and clinical categorization will provide context and data to address key research questions. So next one also linked with, next two bullet points also linked with risk factor. One is related to the infectious disease such as measles or malaria or HIV. So infectious disease as a possible risk factor for NOMA were detailed in 22% of included publication in this document. But future NOMA initiatives should leverage existing health infrastructure and a program for related to infectious disease to strengthen awareness and case detection and treatment and referral. Because, without only we are doing the case surveillance or early detection NOMA, that is not, cost effectiveness. Therefore, it is important to identify any opportunity, especially as we mentioned that the more than 50% of publication mentioned that infectious disease is a possible risk factor. Therefore, it is a great opportunity to integrate NOMA as a part of the existing infectious disease activity to strengthen awareness and case detection, treatment, and also referral. Then the third component is also quite similar with risk factor. This is also a risk factor. The malnutrition was the most frequent reported word across the included publication when examining risk factor. Therefore, as like an infectious disease case, it is also quite important to identify opportunity for the integration of a NOMA as a part of the existing nutrition campaign, such as community-based screening campaign for NOMA should be incorporated or aligned with existing infrastructure, which target nutritional status and growth monitoring and intervention. Then another point is, this is linked with microbiology. So paucity of information and limited reporting on microbiology of NOMA. So the association and also load of difference microbiology in the development and progression of NOMA is unclear. And with more than 110 different microorganisms observed across reported NOMA cases in this scoping literature review, therefore, urgent need for research on NOMA, microbiology, pathology, and histopathology, and also improve reporting on culture methods, because throughout this scoping literature review, many of the papers did not define the methodology of the cultural method. Therefore, it is also quite important to improve reporting of the cultural method, and also applying WHO 5 staging, and also the conducting longitudinal study in high-risk area for this. Then another component is actually case reports suggest early intervention during the necrotizing disease virus using oral hygiene or debridement or antibiotics and the chlorhexidine. Promote healing without long-term effect, but robust studying on prevention efficacy are lacking. I mean, we already have some of the potential intervention, but actually the robust study on prevention efficacy are still lacking. Therefore, in order to make strong evidence, program should focus on improving disease knowledge and early diagnosis and rapid referral to prevent severe progression. And also future research should include well-designed cohort study to validate preventive intervention. I think this is maybe last two recommendations coming from this scoping literature review. So the first one is actually few high quality study assess NOMA treatment, and then reported modality vary widely with poor stage specific data. And also even with patient level antibiotic data, heterogeneity in regimen and outcome prevent identify effective protocol. Therefore, future research should use robust design with larger cohort and report outcome by NOMA stage, which WHO already recommended this 5 stage. And also the research community should standardize poor outcome and then treatment protocol, follow-up interval, and a case report form to enable meta-analysis. And then WHO guidance on early detection and management remain recommended until better evidence coming. Then final recommendation is reported NOMA case fatality rate has decreased substantially over last 100 years. However, there is substantial population bias and study design bias because mostly case reports, and with most experts conservatively assuming less than 30% of patients affected by NOMA would reach a care center. Therefore, I mean, we try to identify or estimate the mortality rate. I mean, you try this 30% of patients affected by NOMA, but we also need to strengthen the community-based surveillance to describe the more better, quality of mortality rate of the NOMA is, required. So this is coming from this scoping literature review. This was done in collaboration with Oxford team and also WHO headquarters and also regional office for Africa. So next point is actually tool. Especially this year, we produce various online various advocacy material in order to raise the awareness NOMA. In the beginning of my presentation, I also show you the one of the NOMA video, which is actually tailored for the policymaker and also public health professional, public health practitioner. But we also had a social media tile on NOMA and also other animation video, which actually for community, which raise awareness of community in order to early detect NOMA. And then we also produce human story video from Ethiopia. So I will provide more detailed information from Ethiopia information the next slide. And then as you know that in 2022, we developed the first online training course on NOMA in Open WHO, but now we also transfer this course into the WHO Academy. So you can actually access this WHO Academy course through scanning this QR code. This material is accessed in English, French, Hausa, Hindi, and Portuguese. And then the country, for example, when we work together with Ethiopia, the Ethiopia Ministry of Health actually utilize this material to train primary care worker and a community health worker. But also it is also very, relevant for oral health professional and the NTD professional refresh your knowledge on NOMA. So all the material you can download scanning through this QR code. Then country level activity. So we actually supported, especially last year, Benin, Senegal, Ethiopia, and Mozambique. And then actually we are currently also working together with Madagascar as well. So Benin and Senegal. So during the surveillance presentation, I talk about the global NTD annual reporting form called GINAF. So we train Benin and Senegal to reporting NOMA case through GINAF, but also we support them to organize stakeholder meeting because in Benin and Senegal, before NOMA was integrated as a part of the NTD, oral health team actually leading the Noma Control Program. But now Noma is a part of the NTD program. Therefore, we try to facilitate this stakeholder meeting, oral health and NTD and the other, sectors such as, universal health coverage or nutrition in order to foster collaboration to tackle Noma. And then Ethiopia, so we work together with Noma and also skin NTD team for the training for primary care and a community extension worker in view of the inclusion of Noma into the national NTD master plan. And then the next slide, I also provide more detail about this active case detection, but Ethiopia actually tried to integrate Noma active case detection as a part of the mass drug administration of ivermectin for onchocerciasis in order to case search of Noma. Then Mozambique, we actually support to the resource mobilization plan for Noma after we supported them to do the rapid assessment of the Noma situation in Mozambique in 2023. And then we also try to support Mozambique to integrate Noma into their national NTD master plan. And then this slide, I did not include the Madagascar information, but currently we also work together with Madagascar in order to identify Noma case, through the rapid national Noma assessment situation analysis. So as mentioned that this year and last year, we support Ethiopia for the active case surveillance. So strengthens the capacity for detection of Noma through the implementation of active surveillance of Noma during mass drug administration of onchocerciasis. So in collaboration with NTD team, we trained around 240 community health workers with around 2,400 oriented volunteer community members, and then we assisting them in reaching around 1.2 million individuals for the active case surveillance. So actually, in the plan of the mass drug administration, so NTD team planned to reach the 1.2 million population. Therefore, we leverage this opportunity to integrate active Noma case detection for this mass drug administration. So we actually reach 1.2 million. So as you notice that if we only do the Noma screening, we could not reach such, a big amount of the population, but we actually try to integrate Noma case detection as a part of the mass drug administration. Therefore, we could reach the 1.2 million population during this active case surveillance. Then actually, through this active case surveillance, we could identify 3 Noma cases at the early stage in December 2024. And the good point is that, of course, before we start to work with Ethiopia, we actually also did the rapid assessment of Noma in Ethiopia, and then we also could identify the retrospectively around 70 Noma cases in Ethiopia. I think until maybe around 2015, but we did not have a prospective Noma data. Therefore, this new case finding actually convince and support that Ministry of Health include of Noma in the next national NTD master plan. So this photo shows that community extension worker asked mother for presence of Noma case in her family by showing picture of a Noma patient while providing medicine for onchocerciasis. So human story video, during this active case surveillance is we also make a video Therefore, you can also see this video through scanning this QR code. So this is my final slide. So of course, in 2 years, our progress is a little bit slow, but we have some tangible progress after integration of NOMA into NTD. But we need to work together in order to accelerate the NOMA control effort, globally. Therefore, I highlighted the 6 next step, or 6 recommendation point, which we need to accelerate the progress for the NOMA case control. So firstly, inclusion of NOMA control effort in National NTD Master Plan, or oral health policy, or any other relevant national political document in order to provide a strategic guidance direction, and also improve the political awareness in countries. And then integration of NOMA into surveillance system, but this is not only the passive surveillance, because not so many potential NOMA cases come to the health facility. Therefore, we also need to integrate NOMA as a part of the active case surveillance, such as mentioned, that mass drug administration of the other NTD, or nutrition campaign, or vaccination campaign. And then, because as mentioned that initially, the NOMA community is, mainly oral health, community, but we need to work together with different partners such as NTD community, oral health community, nutrition community, and the NCD and vaccination, and the expansion network and partnership, and the community of practice, including the people lived with experience. And then the 4th point is, mainly a recommendation or next step for researcher. The prioritize NOMA research by using standardized reporting in line with WHO staging, 5 staging, and also collecting patient-level risk data, and then leveraging existing health system for screening and also early care, and also advancing microbiological and clinical research through robust and stage-specific cohort and standardized outcome. At the same time, because still many people do not know about NOMA, and also we need to capacitate the primary care worker and also community health worker in order to promote oral health and then early detect and then treat and also referral NOMA cases. Therefore, it is also important for the capacity building of NOMA oral health NTD focal point and other health professionals to prevent, detect, and treatment of NOMA. And then the final, but not last, but very, very important. Even NOMA is a part of the NTD now, but still we are limited resource. Both, financially, but also, human resource. Therefore, we also need to continue advocate the mobilized resource to support country in accelerate NOMA control effort. So this is my last slide. As you notice that in order to control NOMA, we need to work, not only the intersectorial approach, not within, the health sector such as oral health, NTD, maternal child health, vaccination, health system, strengthening, health promotion, nutrition, but we also need to work multi-sectorial collaboration such as poverty reduction, human rights, WASH, education, community development. Therefore, it is quite important for these inter and multi-sectorial collaboration to fight against NOMA. Then the final slide, because as mentioned that we produce a lot of advocacy material which can be useful for both policy maker level, but also community level. So we integrated this material into our WHO Africa regional website for oral health, but also you can access some of the materials through scanning these 2 QR codes. So thank you very much. Over to you, Dr. John.
Dr. Makino, thank you so much for such a wonderful presentation. We are so grateful and so excited to hear about the updates from the WHO. We'd like to invite anyone who'd like to raise their hand and ask a question, or if you'd like to put a question in the chat, we're happy to read that out. I see Dr. Bala has his hand raised, and we'll turn that over. Dr. Bala, would you like to ask a question?
Yeah. Thank you, Dr. John. Thank you very much, Yuka Makino, for this wonderful presentation. I love the presentation, especially the systematic review is one of the best systematic review I have come across in the literature. Thank you. My question is in your presentation, you mentioned some data from 4 African countries. And yeah, we all know that Nigeria is an epicenter of Noma disease, whereby if we go by the WHO staging of Noma, we report 100 cases of Noma we have seen here. But there is no report from Nigeria throughout your presentation. I'm actually inquisitive and sometimes worried what happened, why Nigeria is not in the presentation. Thank you.
So thank you very much, Dr. Bola, and also thank you very much for your great work in Sokoto Hospital. Because actually integration of Noma into NTD was led by Nigeria. So congratulations for your great success and effort to control Noma. So in terms of the surveillance, as mentioned that we try to integrate Noma into this global NTD program annual reporting form called GNAF from 2024. Therefore, which I show you, the data is actually first year data reporting coming from a country. Therefore, only maybe around 7 countries reported NOMA cases. And then unfortunately, many countries did not report NOMA case through this platform because it was the first year to start to integrate NOMA as a part of this GNAP. Therefore, unfortunately, even we know that Noma is actually, one of the high disease burden country of Noma, but they could not manage to report, especially in 2023 through this GNAF reporting system. But we try to continue advocate our NTD, the Ministry of Health NTD focal point and also oral health focal point in collaboration with our NTD team colleague in order to obtain the data reporting from each country through this GNAF platform. Thank you very much.
Thank you. I see Michael has his hand raised. Michael, would you like to ask a question?
Yeah, thank you, John. And thank you, Makino. This is really, really good for us in terms of understanding advocacy efforts. My question is just maybe the last part of Dr. Bala's question, to just zoom in on some details to say who is responsible for submitting this data to GNAF in countries, like who represents, which office of the Ministry of Health, is responsible for submitting data to GNAF. Yeah, just to know, from different countries. Thank you.
Thank you very much for this question. So maybe you also try to advocate that the person who is responsible for reporting NTD information to GNAP. But depending on the country, the situation would be potentially different. But especially in our region, normally focal point is actually NTD focal point in Ministry of Health. But we also encourage involve the oral health focal point, especially the report in NOMA case in collaboration with NTD focal point in Ministry of Health colleague. Thank you very much.
Thank you. Thank you so much. Laura Verducci, would you like to ask your question, please?
Yes, good morning. Good morning to everyone. And thank you a lot for this presentation and also for this strange birthday, no? And I want just to introduce myself. I'm an anthropologist, and I'm doing my studies in Ethiopia and also in Laos, where I will go the next year. And starting from a Farley study that are very interesting, I'm trying to studying and let's say all the community practice, but not also practice, but custom and used to live that maybe can improve the region of Noma. I want to say that in some case, some way to act of the community could be elements of co-origin of the disease, and so I'm studying in that sense. For example, in Sokoto, in the north of Nigeria, the child doesn't have a name until 1 year, and in my opinion, it's a very strong point about the spread of Noma and the origin of Noma. So close to all the, let's say, the medical causes and the poverty causes of Noma, maybe we have to try to understand also the dynamics inside the community where Noma came. That's all. Thanks.
Thank you very much for sharing your planned activity, because as mentioned that I'm also working together with currently Ethiopia related to Noma control efforts. And then we also could identify several cases of Noma in Ethiopia. Therefore, I mean, your research will be very interesting. But at the same time, as I share with you systematic scoping literature review, and then I also share with you the QR code. Therefore, you can also download this document later on. But in terms of risk factor, as mentioned that through this scoping literature review, we could identify more than 200. But the issue was that the causality and also, I mean, interdependency of many poverty-associated risk factor, because, I mean, as you mentioned that, I don't know whether, I mean, there's no name child, I mean, until 1 year old. I don't know whether that factor also linked with maybe poverty issue. I mean, therefore quite challenging to understand the accurate tease out or given the level of the reporting. Therefore, we also need to think about, how we can identify better statistical methodology in order to, controlling the confounding factor, especially poverty, because as mentioned that more than 200 risk factor, many of the potential risk factor is related to poverty. Thank you very much.
Thank you. Dr. Coker, would you like to ask a question?
Hello, everybody. Thank you, John. Hi, Yuka. So nice to actually listen in. I'm sorry that I came in late, but one of the things that I want you to kind of elaborate on is the definition of Noma. And I see Dr. Ramat here, and I would like to just kind of also have a quick discussion about your concerns about the current classification and how we can make it better to kind of be more inclusive of what we're seeing in the regions right now. Thank you so much.
So maybe it is good I can share my screen because Dr. Dupe, are you familiar with the 5 WHO staging categorization?
Yes. So I just was
Okay.
wondering if we can talk about that a bit more, given what we're seeing. And I'm hoping that Dr. Ramat can also jump in, because I think maybe some of that is not generalizable.
Thank you very much. So for your information, currently we are WHO had a 5 stage of Noma. The stage 1 is actually necrotizing gingivitis. Stage 2 is actually endema stage, and then stage 3 is actually ganglion disease, and then stage 4 is actually scarring stage, and then 5th is actually sequel stage. Because I know some of you already expressed concern about maybe stage 1 and 2 would be pre-Noma stage. But at the same time, from the WHO perspective, because we do not want to miss the potential Noma early stage of Noma in order to reduce mortality of Noma, therefore we also integrate the stage 1 and 2 as a part of Noma in order to encourage the early detection of Noma. And then even we produce this information brochure on Noma, which actually recommended this 5 Noma stages in 2017, but not yet many, researcher or country aware, and then not yet utilized. Therefore, based on this scoping literature review, in order to better understanding Noma and also better quality of Noma data, we also encourage to utilize this 5 stage at this moment. But anyway, if Dr. Cook or other colleague also would like to provide any comment related to this current staging, I mean, please feel free to intervene. But anyway, Dr. John, over to you.
Sure, thank you. I think Dr. Bala, would you like to make a comment as well? I see you unmuted.
Yeah,
And then perhaps
because you know
Dr. Brema.
the comment I have, I think you know, because what WHO is saying, if you have necrotizing gingivitis, is also a case of Noma. So because going by that, you know, I think there is risk of misguiding the epidemiology, because now necrotizing gingivitis have been seen around in Nigeria almost in every primary healthcare and other dental centers. But I know it's just a caution that if the WHO should make plan for revisiting this staging, I think it will be good for the epidemiological data, because not all necrotizing gingivitis progresses to normal. We have large number of patients that have necrotizing gingivitis which don't actually progress to normal. So I'm sure what Dr. Coker is trying to caution is, if the WHO can, since we have WHO with us now, Dr. Yuka Makino, so if you can actually make plans and revise that classification, maybe what Khamisa et al., if you read the paper by Khamisa et al., I think that paper is beautiful. Normal precursors is better used in stage 1 and 2.
Thank you so much, Dr. Bala. Dr. Brema, would you like to make a comment as well? I saw you had raised your hand for a moment.
Yeah, thank you very much, Bhutan, John. Nice to see your face again. It's really very, very important. Just a rider from where Dr. Bala dropped it. Now that we have WHO, we really quickly need to call for the review of that staging of Noma. Like we said, Kimasa et al., if you read that paper, and even if you read the paper that we have been releasing from Sokoto, you will see that cases of to stage Noma as to stage acute ulcerative gingivitis as a stage of Noma is really, really misleading. But unfortunately, children that have this condition, that you cannot leave them and say you want to see if it will progress to Noma. That is very, very unethical. Okay, and so you see that there is a sharp demarcation on really to now say that acute ulcerative gingivitis is a stage of Noma. I think WHO, we really need to come together, work with the people on the field, the current presentation of Noma now. Because even not all Noma cases start from the gingiva. It start from some start from the mucosa, buccal mucosa, which we have seen and we have reported a lot on that. Thank you very much.
Thank you, Dr. Brema. I see Dr. Adatula Ifi. Would you like to ask a question? Sorry, you've had your hand raised for a few minutes.
Hello, good evening. Am I audible, please?
Yes, we can hear you.
Yes, thank you.
All right. Thank you very much, John. Thank you very much, Dr. Yuka, for the stimulating presentation. Mine is a question about the roadmap. And I want to ask specifically, do we have a particular time the revised roadmap that has that has all the indicators for Noma? Do we have a particular time when it's going to be released for use? Thank you very much.
So thank you very much for this question. So in terms of the Noma disease summary, because I show you 2 dimension. One is actually disease summary. The other one is actually the qualitative assessment in line with the 11 dimension. Disease summary one, including the global target and the milestone of Noma and towards 2030. This draft is already ready, and then hopefully early next year we can publish this material, including the target and also milestone to control Noma towards 2030.
Thank you very much. Mohammed Lawal Abubakar, you have a question?
Okay, so thank you very much. I hope everybody can hear me.
Yes, we can.
All right. Okay, good. So I think I have like 2 or 3 comments. So the first one is about the comment made of the Noma people, patients in northwestern Nigeria, especially in Sokoto, about patients not being named until after 1 year, probably because of the Noma. Actually, that is a misconception. The children are actually named within the first, it's a tradition in northern Nigeria as a whole that kids are named after a week of birth, and which is not too different from Noma children. So, and I don't think that it should be any cause of risk factor or anything associated with the Noma disease. Now, my second comment is regarding the Noma staging, like what Dr. Bala and Brimo have mentioned. I think to avoid confusing other form of necrotizing gingivitis and other diseases that look like Noma, the current staging we are using actually give room to admit other causes of gingivitis that are not Noma into Noma, and that will be like overestimating when you use that. So I think if we are going to revise that, probably adding some other criteria to the current staging in order for it to try in as much as possible to eliminate other diseases that are not Noma. For instance, if somebody has a stage 1 with other features of Noma, such as malnutrition and other things, then one should start thinking of the disease being Noma. The third comment I want to make to the presenter is that, yes, I was quite intrigued by her comment about how Noma is now being added to the NDT, to the all the NDT surveillance. I think that is the way to go. In order to invent the wheel, other structures for other entities have already been established. So all we need now is to include Noma in all the steps of other MDTs so that you don't have to have, like in quotes, a new program for specifically for Noma. And when it comes to field survey and other things, we can actually simply borrow and modify other NDT programs to suit Noma rather than reinventing the wheel. Thank you.
Thank you very much. And I'd also just like to make a quick comment on that, especially since it seems that a clear case definition of Noma seems to be something that's surfacing in the group as a priority. There's a paper that was recently published earlier this year defining the Noma research agenda and talking about what the priorities for Noma research moving forward. And the first priority, I believe, on that paper, one of the first priorities was that clear case definition. So certainly moving forward, and I'm sure the WHO is working on this as well, talking about what is a case of Noma, should ANUG be included in that case definition? Should it not? Certainly is a great topic of conversation. And I would direct others and people on this call to perhaps look at that defining the Noma research agenda paper. So that would be something might be interesting for those on the call. Was there another question? If not, I want to thank everyone for joining us this special and exciting occasion of the 2-year anniversary of, oh, yes, I do see a question. Halima Mohammed, would you like to ask a question?
Yes, thank you very much. Good evening. Actually, I want to know how, anyway, I just made the presentation halfway Oh, I didn't even meet most of the presentation, but my question is, I want to know the extent to which WHO is taking measures on assessment and awareness of this NOMA campaign within the rural communities where this particular disease is endemic. So I want to know the type of assessment disease. And I know we use the 3 stages. We have the 3 stages which we usually follow for diagnosis of this NOMA. But I just heard of the 4 stages. The last one, I'm not clear about it. So I just want a brief explanation about the last one of the 4 stages mentioned here, because I know the one that I know which we use is the stage 1, stage 2, stage 3 of tissues, and the last stage, which is the extensive tissue destructions and deformity. So I want to hear about the last one, and to the extent which we go into awareness of our community members and how to enlighten them, because at the rural level, we need much commitment of education, awareness of our people to know from the very beginning how to identify this disease from acute necrotizing ulcerative gingivitis. As I've heard someone mention earlier, that not all ANUC extend to become a NOMA. Yes, definitely not. But how can they be able to know and get aware of it from the very, very beginning? People in the rural areas. Please, I want to little more light about that. Thank you. Thank you very much.
So thank you very much, Dr. Halima. So stage 0 NOMA as well. So as you noticed that we have I don't know whether you can see my screen or not. You can see. But anyway, so this is yes. Actually, we also produce this material, especially for the community health worker. Then, as you know, that we put the stage 0 is actually gingivitis, and then the stage 1 is necrotizing gingivitis, and stage 2 is onema, and then stage 3 is actually gangrene, and then stage 4 is scarring, and then stage 5 is actually sickle. So, I mean, the point is that if we only do the raising awareness NOMA, that will be not, I mean, cost effectiveness, and you cannot reach the population which you like to reach. Therefore, I mean, as mentioned during my presentation, you also vaccination, because I mean for example, measles or I mean the malaria is actually potential risk for NOMA. Therefore, you need to utilize these vaccination opportunity to raise awareness NOMA and also early detectable NOMA. And another point is nutrition, malnutrition, also another potential risk factor NOMA. Therefore, you can also leverage this nutrition campaign opportunity among a community to raise awareness NOMA. Utilize this, 5 stage of NOMA. Therefore, you can have a lot of great opportunity to integration of NOMA awareness as a part of the other potential important NOMA risk factor. Therefore, I hope you can do this integrated approach rather than you are doing the individual awareness campaign on NOMA. And then I also attach the NOMA video, because in the beginning, actually, I show the video for the policymaker, but we also produce the video for the primary care level and also community level. So maybe depend on your context, because I know that Nigeria team, they try to translate this one into the local language. Therefore, potentially, Dr. Harima, in your community, maybe you also need to, change your this language. But this one is, show the story of the girl trying to save the life of the younger brother. He potentially infected are affected by Noma. Therefore, this kind of communication material would be also useful to raise awareness of Noma among the community. I hope I responded to your question, Dr. Harima.
Yes, clearly, Dr. Mam. Thank you very much. Thank you. Well done.
Again, Dr. Makino, thank you so much for joining us today. Lovely to see you again, and thank you very much for everyone for joining us again on this 2-year anniversary of NOMAs being added to the WHO's list of neglected tropical diseases. We're very happy to keep in touch with everyone and extremely excited to hear this lively discussion at the end of the webinar. So please, let's keep the discussion going. Please visit our website, www.internationalnomanetwork.org. Feel free to reach out to us. We're very happy to keep this conversation going. Thank you to everyone for joining. We hope you have a safe, happy, and healthy holiday season, and we wish you all very well. Again, Dr. Makino, thank you.
Thank you so much for your great invitation and also lively discussion. Thank you so much.